Welcome to Department of Medicine Grand Rounds, everyone. My name's Celia Herring. I'm one of the inpatient chief medical residents here at UW-Montlake, and I'm excited to be facilitating today's session. Today, in addition to our usual Zoom audience, we also have a live audience joining us from with our speaker at Harborview. If you're attending virtually, please submit your questions through the chat per our sort of usual procedures. I'll be collecting those to pose to our speaker at the end following any of the live audience questions. And now I'm going to hand things over to Dr. Gerontology Chander, head of our Division of Internal Medicine, to introduce our Grand Round speaker for today.
Great, thank you so much. So it's my pleasure to introduce Dr. Inouye today. She is our Pecoraro Lecturer for General Internal Medicine. This lecture is in honor of Dr. Roger Pecoraro, who died in 1991 at the age of 48 from cancer. He was an attending physician here at the University of Washington and the VA. He pioneered research on the causes and prevention of foot ulcers and amputations in people with diabetes. And I think what's really important to note about him is that it was really through his work in the early treatment of leg wounds among people with diabetes that they saw the number of amputations diminish by 20%. So a true leader in his field. So our annual speaker, Dr. Inouye, was invited through division nomination and vote. She is a professor of medicine at Harvard Medical School and the Milton and Shirley F. Levy Family Chair and Director of the Aging Brain Center at the Hinda and Arthur Marcus Institute for Aging Research. She's the editor-in-chief of JAMA Internal Medicine. She has made a significant impact on the health and medicine through her really seminal research in cognitive disorders of aging, including delirium and dementia. She has combined her clinical acumen with expertise in epidemiology, public health, and public policy to really revolutionize the way we provide clinical care for older adults. She's been continuously funded by the NIH since 1989 with over 90 grants, including an NIH P01 grant and a large PCORI contract. She's published over 400 articles. She's had many recognitions and awards. She has received the Leonard Tao Humanism in Medicine Award from the Gold Foundation, the Henderson Award from the American Geriatric Society, and numerous others. She's an elected member of the American Society of Clinical Investigation, the National Academy of Medicine. She is a true dedicated teacher and mentor, in addition to clinician and scientist. We're very excited to have her here today to talk about delirium during hospitalization. Thank you, Sharon.
Thank you, Dr. Chander, and thank you to everyone here in the Division Gen Med and the Department of Medicine. I'm really honored to be here to present your Grand Rounds. Can you hear me okay? Wanted to confirm.
Yes, we can.
Fantastic. Thank you so much. So I am going to focus my talk on delirium during hospitalization, and much of what I'm going to present also focuses on older adults because I am a geriatrician and much of my research work has focused on older adults. So I have no conflicts to disclose. My interest in delirium really started at the bedside, where I saw that older adults often became confused during the course of hospitalization. And this really precipitated me back in the late 1980s to start looking at this issue, which really at that time when I started, delirium was considered just sort of an inevitable part of hospitalization for a lot of older adults, and it wasn't felt that there was anything to be done about it. And that there was very little research work done on it at that time, and I really felt that I questioned whether it had to be an inevitable part of a hospitalization. And so that's how I got started in the field of delirium research. So what is delirium? Well, the official criteria are shown here. And these come from the Diagnostic and Statistical Manual of the American Psychiatric Association. And the criteria are a disturbance in attention, accompanied by reduced awareness of the environment. The disturbance tends to develop acutely and it tends to fluctuate, meaning it comes and goes over the course of the day. There's an additional disturbance in cognition, such as a memory deficit, a language impairment, or visual perceptual impairment. And there's evidence of an underlying organic etiology or multiple etiologies. And so you can see from these criteria that delirium really is at the intersection of a psychiatric or behavioral condition and a medical condition. But it definitely falls firmly into the region of something we need to know about in internal medicine, because there is a precipitant, an underlying medical etiology or multiple etiologies, which are typical in adults. And why should we care about it? Well, it is a very common problem. It was dramatically decreased during COVID-19. It has serious complications. I'm going to detail those more in a moment. It has very high healthcare costs. It's distressing to patients, families, and healthcare professionals. And I think that person-centered orientation to delirium is gaining increasing traction now, in particular as we try to attend to improving quality of life for patients and their families. And up to half of cases may be preventable. And so I think that's really important to stress for us as healthcare providers. So in US hospitals today, 5 older adults become delirious every minute. And if you just think about the scale of that, even during the course of this talk, many hundreds of patients are going to become delirious. It's 2.6 million older adults develop delirium each year in the United States. And delirium is extremely common. And so if you look at prevalence on admission to the hospital, so that's how many patients come in with a mental status change or an acute confusion, it ranges from about 14 to 24%. And this comes from several literature reviews that I've done over the years, just quantifying what's been published in the literature. The incidents are new onset during hospitalization, so this comes on top of that prevalence, is an additional 6 to 56%. So you have to add up these numbers to get the total occurrence of delirium during a hospital stay, and it's going to be between 20 and 80%, particularly in older adults. It's also very common in a postoperative setting, in the intensive care unit setting, nursing home and post-acute care, and palliative care. And you see the rates here being very high. Another point that I want to stress is the case fatality rate. Delirium is an incredibly morbid and often fatal condition. During the hospitalization itself, about 22 to 76% of patients will die during that hospitalization if they develop delirium. And then if they survive the hospitalization, additional 1-year mortality of 35 to 40%. So one thing that I want to stress, because you're going to hear me talk about delirium is often unrecognized during hospitalization, is these mortality rates are just as high as acute myocardial infarction and sepsis, and those are conditions we rarely miss, whereas the mortality with delirium is just as high, but it's unrecognized in up to 70% of cases, even to this day. So delirium has very serious complications, as I've already stated, increased morbidity, already talked about the increased mortality, also functional and cognitive decline, increased rates of dementia. I'm going to talk a little bit more about that later in the talk, high degrees of need for institutionalization, increased length of hospital stay, and high healthcare costs, post-traumatic stress disorder, and tremendous degree of caregiver burden. I'm going to talk a little bit more about those in just a moment. So delirium is very expensive. From studies that I've done, as well as many other groups, we've documented the increased hospital costs. So these are excess costs associated with delirium at over $8 billion per year in the US, just for prolonged length of stay, the need for more intensive services, the need for intensive care, and so forth, that is associated with delirium. So delirium is very costly to our hospital systems. But the more dramatic increased costs come in the post-hospital setting, where we have over $150 billion per year, and that is for rehospitalization, institutionalization, the need for formal rehab, the need for formal home care, and then this tremendous degree of caregiver burden, and that we don't actually even factor in the out-of-pocket expenses here for the caregivers or their economic losses, such as losses from work and so forth. So I want to talk a bit about the patient experience of delirium, sort of this person-centered aspect of delirium that's gaining increasing traction and attention. So we did a qualitative study back in 2019 where we interviewed patients, their family members, and their nurses in patients who survived the experience of delirium. And these were 30 to 60-minute qualitative interviews by trained interviewers, and they were recorded, and we had transcripts prepared. And then these results were synthesized in this paper published in the Gerontologist in 2018. And I pulled out just some of those quotes. And I have to tell you, by this time in 2019, I had already been working in the delirium field for over 35 years. And yet reading these transcripts, I have to admit that I was just moved to tears to read about the experiences that the patients were reporting who were able to remember and obviously survive the delirium and to report on that hospitalization. So here are some of the quotes. I was afraid, not knowing where I was. I was not able to say what I wanted to say. It was very scary. I was outraged that I should be treated this way, with chiming beds and people coming out of walls. And so just to reflect on what that experience is like for the patient who's delirious, you know, I hadn't really thought about that. I hadn't really dwelled on it in my prior work, but I can tell you now, whenever I'm called to the bedside to see or evaluate a patient, this is in the top of my mind, how helpless patients feel, how terrified they are, how they can't understand what's going on with them. And it helps me to be more patient, to take those extra steps in communicating, in trying to be calming, in trying to let them know what's happening. It just gives me that extra, oomph to avoid just prescribing medication immediately, or, certainly trying to avoid physical restraints. So I've talked about how often delirium is unrecognized, and part of the difficulty, right, is it remains a bedside diagnosis. So there's no lab test, there's no biomarker imaging study we can do to establish a diagnosis of delirium. There's a lot of work in this area, but really the gold standard right now is a bedside assessment. And it does have to include cognitive testing, which can be very brief. And I'm going to tell you about a very brief approach that's based on the confusion assessment method, or the CAM. And this is a tool that I developed when I was a fellow and just getting interested in this area. And it remains the most widely used method worldwide. It's been used in over 5,000 studies to date, translated into over 20 languages. And it has a very short 4-item diagnostic algorithm that's used very widely. And so those 4 items are here. They're acute onset and fluctuating course. You'll remember those from DSM criteria. Inattention, which is a reduced ability to pay attention to what's going on in your environment or to follow a conversation. And so that's a key element. And then disorganized thinking, or the fourth element, altered level of consciousness. So you have to have one or the other of those. And then I'm going to show you on the next slide a way to measure those very quickly and efficiently. The CAM, though, also includes a longer version, a 10-item version. And this is used in a lot of research studies because it allows you to characterize delirium subtypes, hyperactive or hypoactive. It also is used by studies as a diagnostic reference standard. And so I just want those of you who are researchers to be aware of the long CAM. And you can find information about both of these versions of the CAM here at the American Delirium Society's website. Now, I mentioned to you a short way to rate the CAM, and I'm very, very excited to let you know about the ultra brief CAM, affectionately known as the UB CAM, and that's available. Ooh, how do I make those boxes go away? Is everybody seeing boxes on their screen? Okay, all right. So hopefully you can see the scan for iPhone and for Android, where you can download the UPCAM app, Ultra Brief CAM. And this will allow you to do a delirium assessment that's highly sensitive, over 90% sensitive, and over 90% specific. And that means, the sensitivity means when delirium is present, you're going to pick it up over 90% of the time. And when delirium is not present, you're going to rule it out over 90% of the time. It takes less than a minute, and the app will take you through things step by step by step. And so it starts with a rating of just the level of consciousness of the patient. Are they able to respond to you? Are they able to answer questions? Yes or no? And then you check the box. And then if they are able to respond, it takes you to what's called the UB2 screener, where you ask the patient to tell you the day of the week. And then you ask them to tell you the months of the year backwards, starting with December. And those are the two cognitive items. And then depending on how they answer, it will take you through in a branching algorithm the subsequent questions, but it allows you in less than a minute to make a delirium diagnosis. So I hope you might use that. I hope you might spread that to your teams and let them know there is this highly valid and reliable way to recognize delirium. Okay, the question that I get asked over and over and teach to all my teams is, how do you differentiate delirium from dementia? And it can be very tricky, right? Because when someone is admitted who has dementia, they will also be confused. They may have, disorientation. They may have memory impairment. And so it can be hard because both of those things are present with both delirium and dementia. And so really you want to go back to those CAM, those diagnostic criteria. And so with delirium, the onset, the change in the mental status is typically abrupt over hours to days. And with dementia, the onset is insidious and progressive over months to years. Now, if someone with dementia develops an acute abrupt change, then you need to consider that as a delirium until proven otherwise. So you want to do the workup for delirium that we're going to talk about, okay? Until you can confirm that the patient is at their baseline. With attention, delirium, it's impaired by definition, and you can assess that, again, by utilizing that UBCAM. So the months of the year backwards is a really good test for sustained attention. With dementia, it's normal unless you're in the very advanced stages. with delirium, level of consciousness is often fluctuating, typically reduced, but it can fluctuate between hyperactive and hypoactive, and it can be normal. You can have a normal active delirium as well. With dementia, level of consciousness is generally intact unless you're in those advanced stages. And I say generally because there's always exceptions, right, to the rules. Delirium, the speech is often incoherent and disorganized. You have a hard time following the patient's train of thought. And when dementia, the speech is ordered, they may have aphasic, anomic errors. They may manifest disorientation in their speech, but you can follow how one thought, comes after the other. And I already mentioned with delirium of hyperactive and hypoactive forms. And with dementia, you can have agitation. The psychomotor changes are a little bit more unpredictable than in delirium. Okay, so let's move on to what causes delirium. And it's very, very many different things. And so I kind of want to prioritize for you to help you in your workup. But first, starting with the pathophysiology of delirium. And it's very important to know that we don't really understand, as of this date, the fundamental underlying pathophysiology of delirium at a molecular level. There's a tremendous amount of research going on in this. It's probably multiple different mechanisms with a final common pathway, but we haven't been able to really target the essential pathophysiology. But these are a lot of the areas under investigation and that I feel are going to contribute ultimately, and hopefully we will be able to develop targeted treatments at these areas that may be able to help. And so things like neuronal dysfunction and injury, either to microglia or astrocytes, are high on the list. Drugs are the leading cause of reversible delirium, and I'm going to talk more about those. Neurotransmitter disturbances that can be caused by drugs or multiple other mechanisms. These can be in the acetylcholine pathway, in the dopaminergic pathway, in a variety of pathways may trigger a delirium. You can have systemic triggers from inflammation, which could be related to a surgery, hypoxemia, decreased blood flow, metabolic derangements, particularly hyper and hyponatremia can cause mental status change, hyper and hypocalcemia, and also hypoglycemia. Very important. Vascular dysfunction is being widely explored, and then just general disruption of neuronal connections are also being explored at this time. Again, we don't know for sure which of these are going to turn out to be the thing that triggers delirium, and again, it's probably multifactorial. And so that leads me to my next point, that I'm an epidemiologist and a clinician, and so this is a multifactorial model that I proposed when I began in the delirium field, and subsequently have been able to do many studies that have validated this conceptual framework. And so now it is widely accepted as sort of the multifactorial model for delirium. And so what I hypothesized is that you have a vulnerable patient with multiple predisposing factors, right? So you think of your older adult who may have mild cognitive impairment, vision and hearing impairment. Let's say they have some, renal dysfunction or hepatic dysfunction. They have multiple comorbidities, multiple chronic illnesses. And then you admit them to the hospital, and they're subjected in the hospital to different sort of precipitating factors or noxious insults during the course of hospitalization. And so those can be things, for instance, and we'll go over them on the next slides, but things like, medications, as we talked about, a major surgery, a prolonged ICU stay with sleep disruption, and so forth. And so when you have a vulnerable older adult who gets exposed to those noxious insults, it's the intersection of those that then can precipitate the delirium. But two important points I want to make are you can take anyone and they can develop delirium with enough noxious stimuli happening. And so even I could take any of us, and I think if I gave you enough of those precipitating factors that I talked about, and I put you in an ICU, general anesthesia, multiple psychiatric meds, I didn't let you sleep for a few days, kept you in the bed, and then I did cognitive testing after a few days. You may not be able to perform as well as your usual. And so that's kind of the principle to understand here and why we see it so frequently in vulnerable patients. And so it's really this combination of factors to think about. And that's also important for us clinically because we're not going to resolve a delirium by just resolving one factor. We have to look and think about this whole multifactorial model to get them out of the delirium. And so these factors came from a systematic review that I did now a number of years ago, but these predisposing factors continue to be validated in subsequent studies. And so this really holds up as sort of the key predisposing factors for delirium for us to be aware of. And you can see the highest risk factors are dementia and pre-existing cognitive impairment. And if you have that present on admission, your risk of developing delirium during the subsequent hospitalization is from 2 to 4-fold increase during the course of that hospitalization. So if you admit someone with dementia cognitive impairment, you're going to want to treat them so carefully, be very careful about their meds, be very careful about what type of anesthesia you administer, and so forth, to try to prevent that delirium. A history of prior delirium, functional impairment and frailty, vision and hearing impairment, comorbidity, depression, TIA and stroke, alcohol abuse, and then the older ages, meaning 85 and older, are all very important risk factors as well for delirium. So these help for you to think about who is vulnerable at the time of admission. And then superimposed on that, the other axis is the precipitating factors. And so these are the things we do to the patient or that occur during the course of a hospitalization, including medications, particularly psychoactive medications and sedative hypnotic medications, physical restraints, bladder catheter, physiologic derangements, infection, iatrogenic events, and then any surgical procedure. And these all increase the risk for subsequent delirium during that hospitalization. So medications are the most common reversible contributor to a delirium. So I do want to spend a little bit of time talking about the ones that are the highest risk. And so these are taken from the American Geriatric Society Beers criteria. They were originally developed by Mark Beers, and now they are updated every couple of years by the American Geriatric Society based on a very strict evidence-based review procedure. And they're listing what they call them is PIMS, potentially inappropriate medications for the elderly. And I want to stress that potentially because obviously medications on this list must sometimes be used, right? They can be life-saving and essential, steroids, for instance, or benzo for, delirium tremens. These are necessary. You can't avoid them. So it's just potentially. I just want you to be aware that the medications on this list, very high associations with development of delirium. Okay. So things like meds that are highly anticholinergic, and I want to call your attention to diphenhydramine or Benadryl because this is available over the counter. And a lot of medications that have sleep in the label, like Tylenol sleep, Motrin sleep. There's a lot of these dash sleep medications. They tend to either have Benadryl or another very sedating antihistamine. They're available over the counter. And believe me, your patients use those. And they're highly anticholinergic. So whenever I'm seeing a new patient in my dementia clinic, I am telling them and their families, I actually give them a list of over-the-counter medications to avoid. Sleep, over-the-counter sleep meds, over-the-counter cold meds, H2 blockers over the counter. Like if before they use those, please let me know. So maybe I can suggest the ones that are safest to use. Antipsychotics, I'm going to talk a lot more about, so I'm just going to note that here. Benzodiazepines, particularly the longer acting ones like, Valium, Librium, and so forth. If you can substitute a shorter acting alternative, that is strongly preferred in adults. Corticosteroids, oral and parenteral. In fact, steroid psychosis is a delirium. Okay, as is ICU psychosis. H2 blockers like ranitidine, meperidine, and other opioids. I want to really call out meperidine, which is Demerol, because it has a very long-acting metabolite that's an active metabolite, and it can hang around in an older adult for as long as 3 to 5 days. And so that is one that you want to avoid, particularly in an older population. And there's so many other opioids that you choose from. Okay, all the benzodiazepine receptor agonist hypnotics like Zolpidem are high risk for delirium. And then antidepressants, antiepileptics, and antispasmodics. Antispasmodics in particular are very anticholinergic, and so you want to be careful. And one thing I want to say is when you have to use meds in these classes, which you have to sometimes, right? Like opioids, etc. In that situation, when it's a psychoactive med, you really want to start low, go slow, and evaluate. Am I using the shortest acting one possible? Am I using the one that's the safest for older adults? And you can get very detailed information on specific drugs from these fear criteria in terms of, equivalent doses and so forth, and the choice of meds within these categories that may be safest for older adults. So I just added this slide because many of you have heard during my time here that I have a son who's a second-year internal medical resident, and he's always asking me whenever she comes to me about a case. He says, "Mom, what is the thing I can't miss? What is the, could you please, if it's shortness of breath, chest pain, whatever it is of presenting." He says, tell me the differentials I cannot miss that could be fatal. And I was like, oh my goodness, I don't even have a slide like that in my talk. So I quickly went back. This is after he asked me about a case just the other day. And I added this slide. Life-threatening causes of delirium, right? And some of them are really rare, right? But they fall into that, let's never miss these. And so that's the purpose of this, right? I was always listing what was most common, what were the things that we have to think about. But, my son is absolutely right. What are the things we don't want to miss when someone rolls into our emergency room or we're called to see them, right? In the intensive care unit or on the floors. So Wernicke's encephalopathy, particularly if you don't know the history, the person's just found down on the ground, consider it, think about it, just adding the thiamine and glucose, can be life-saving, okay? So just to be aware. Hypoglycemia, right? Hypoglycemia can be the great mimic. And so keep it on the list in your mind. Obviously, hypoxia, respiratory failure, acute MI, hypoperfusion, CNS stroke. I don't think that we would miss those. Infection, intracranial mass, epidural, subdural bleed, all of these can always present as a delirium or a mental status change. The one that can be so life-threatening and easy to miss is a herpes encephalitis or other viral encephalitides or vasculitic. And so keep that on your differential, particularly for someone who presents with a fever, right? Or this sudden onset. You just want to keep that in mind. One of those not to miss conditions as classic findings, temporal lobe abnormalities on the MRI or enhanced CT. Okay, metabolic derangements. Added myxedema here because we actually had a case of this recently. Can be life-threatening, right? A lot. There can be signs, right, on physical exam with really delayed reflexes, loss of the eyebrows laterally. Maybe it's someone who you have a history on and know they were on thyroid in the past. But that can be, you know, obviously life-threatening. It's easy to miss. So I just want to kind of call that out. Carbon monoxide poisoning, we had a case of that recently. So I just want to heighten awareness of that. There's always, during the cold weather, we've been having, you know, more risk. And then occult status epilepticus. And I had a case of this now a few years back. But it was just such a wake-up call because it was actually, I had always talked about this when I speak to the house staff, but I had actually never seen a case of it myself. And I had a patient that was transferred to our acute rehab unit where I was the attending. And the patient was being worked up by psychiatry for catatonia because they were unresponsive. Okay. And, you know, I got the history and they had ruled out, you know, metabolic causes and so forth. But I stood in the room for some minutes, just kind of staring at the patient. And I noticed these tiny jerks of the finger, like every few minutes. And I did a very careful neurologic exam. I remember there were just some focal, you know, weakness in that arm. Maybe there was increased tone. But at any rate, ordered an EEG. It was occult status epilepticus. I had never seen a case before. So that presented as altered mental status, working up for catatonia, psychiatric condition. But it was occult status. And when we started the anti-epileptic drugs, patient woke right up. Okay, evaluation of suspected delirium. I am just gonna not walk through this in great detail because of time, but what I mainly wanted to alert you to is this ED-DAL delirium toolkit that I had the privilege of developing with a group of 8 emergency departments across the country during COVID. Okay, so let me tell you how this happened. And if you just search, if you do a Google search on ED-DAL delirium toolkit, it'll be pulled right up. It's free of charge. And it has so many resources if you're interested in setting up your own delirium program. But I have pulled all the subsequent slides I'm going to show you from standing order sets that were developed by this group, which are so helpful because, again, my son loves these, right? They're so helpful for training, you know, and for just kind of teaching purposes. So I want to make you aware of those. And this group of ED physicians, I just have to tell you, they were just so inspiring to me because I started a research project with them pre-COVID, okay, in 2020, early 2020. The pandemic broke out and we were trying to develop, you know, ED standards for delirium. And then they were all crazy people during the pandemic, right? And I turned to them all and I said, listen, I think we need to halt the study, right? You guys just need to go save lives. And I'm taking this research study off your plate. And they said, oh my goodness, no, delirium's more important than ever. We have to do this and we have to do this now. They would not let us stop the study. And so we turned it into high gear. And I said, okay, the focus of our study now is to develop stuff that you need like immediately that will help you in your day-to-day lives. And so we changed all around. We developed these pocket cards or that went on their, with their ID on the back of their IDs that they could hand out to everyone working with them in the ED, on delirium workup, delirium management, delirium prevention. And we had posters. They made these beautiful posters. We hung all around the ED. So we did all this kind of thing. And then eventually when we had time to think, we developed the standing order sets, etc. So you guys know all of this. So I'm just going to stress a few things. The history is all important in delirium. You've got to know if there's been a change. You've got to know if there's medication changes, if there's alcohol exposure, any other exposures that might be of importance. You want to do a targeted physical, you want to do a targeted neural exam. And then you want to do, you want to rule out the routine things, right? And then don't forget about if they're anticoagulated, check that. Always have a high suspicion for MI. And I for older adults, I just routinely send a troponin level. If infection is suspected, and again, have a low threshold, you want to rule that out. So if the white count or fever, or if it's, you're just concerned there's a cough, any other symptoms, low threshold. Okay, these are additional tests, not to do on everyone, but targeted based on what you find in the first part of your workup, okay? You do not routinely need to get brain imaging. I'm always asked about that. I really reserve it for patients, right, where there's some reason to do it, or if there's any focal neurologic change or any history of falls or head trauma within the past week, and I'm really kind of liberal with that in older adults too. If I actually see bruising anywhere on their upper body, I will go ahead and get a non-contrast hit CT. But that's kind of my indications. I don't routinely get it on everyone. So I want to talk about prevention of delirium because that remains the mainstay of delirium management, is preventing delirium from occurring in the first place. And we know it's preventable in at least half of cases. And so I developed this multi-component intervention strategy. It's now called the HELP, or Hospital Elder Life Program. And it's based around multi-component strategies without drugs targeted towards these 6 risk factors. So cognitive impairment, sleep deprivation, immobilization, vision and hearing impairment, and dehydration. So if you admit a patient who has any of those factors present, then you want to try to make sure as best you can that these things get done. So things like orientation and communication, therapeutic activities, that means just fun activities that keep people engaged, brain games, things they enjoy doing at home, crossword puzzles, word games if they enjoy those, looking at photos, reminiscence activities, and so forth. If you can develop a help program at your hospital, we will help you get all of this set up with the use of trained volunteers or training your own staff. A non-pharmacologic sleep protocol, that's a glass of warm milk or herbal tea, relaxation music, and some type of massage, really, really helps with sleep. We also teach nursing about a sleep enhancement protocol, basically how to make the unit more quiet at night by methods that were developed by our nursing services. Early mobilization and minimizing mobilizing equipment. And if there's only one thing you can do, mobilizing your patients, specifically walking, is probably the most potent intervention for preventing delirium. Getting your patients up and walking, getting them back into self-care is the most effective thing you can do for someone to assist them in their recovery. If they are vision and hearing impaired, you do want to provide aids. You do want to train your staff to communicate with vision and hearing impaired patients. And you do want to recognize and replete for dehydration. And so this is the help team that I developed for that original program. And the program is still in effect to this day. And it's been set up now at hundreds of hospitals around the world. This is a volunteer walking with a patient up and down the hallway. And this patient is also wearing a very inexpensive audio amplification device. It just amplifies sound and can really help with communication. The nurses love them because they can communicate with the patients. And so just think about keeping a supply of those available for your patients. This is a volunteer doing a therapeutic activity. It's a reminiscence activity with a patient. And I think if you just look at those faces, you can understand why patients loved the help program and why we have tremendous volunteer longevity with the program. And it got to the point at Yale where I set up the program that patients would refuse to go up to units that did not have the help program when they were in the emergency room. And I was getting calls by the president of the hospital saying, "You got to do something. This patient won't go up to their room." And I'm like, "There's nothing I can do. Why don't you put help on every unit?" And so that's what he did after the 10th time that happened. So help is really a high touch, low tech program, but really a way for us to take very good care of older adults in the hospital. And it works. So this is a systematic review, and this was done by one of my mentees. We reviewed the world's literature as of that time in 2015. These are 11 clinical trials that looked at health-based models, and she found a 53% reduction in the odds of delirium if you did help type program at your hospital. Help also prevents falls. We weren't targeting towards that, but it's tremendously effective for prevention of falls. And so another reason many hospitals are interested in the help model. Again, if one of the main interventions is maintaining mobility and independence. And so that's the way you prevent falls. You prevent delirium, you prevent falls. Help also helps with all these other outcomes. Decreases cognitive functional decline, decreases hospital length of stay, reduces nursing home placement, reduces readmission within 90 days, reduces the need for paid companions at the bedside, and it reduces costs. About $1,000 per hospitalization per patient with delirium prevented, and about $10,000 per patient in long-term nursing home costs in the year post the delirium. So I wasn't able to show you all those studies. Believe me, they're there in the literature. So how do we treat delirium? Again, once delirium occurs, much more difficult to get patients out of the delirium than to prevent its onset in the first place. But you first want to start, of course, by identifying and treating the underlying cause, the risk factors, and then always assess for pain and discomfort, keep the patient hydrated and safe, If they are, very in an agitated state, you want to make sure they're on aspiration precaution, injury precaution, blood and pressure ulcer precautions. And please avoid the use of chemical and physical restraints if at all possible. Multiple studies have shown that those both chemical and physical restraints make delirium worse. They make it longer lasting and can actually lead to poor outcomes. Of course, if the patient's a danger to themselves, they're going to extubate themselves. If they're going to pull out their central line or dialysis catheter, you may have no choice, but I would reserve it for those situations where they really pose a danger to themselves or others. I think things just like vocalization should not be an indication to restrain or to treat with antipsychotics. Because the current evidence from multiple clinical trials, even one in the New England Journal last year, multiple systematic reviews, is that antipsychotics, are not helpful for treatment of delirium, either Haldol or the second generation antipsychotics. And so you want to reserve them for when you really have no alternative. And there is a suggestion that they may increase mortality and they do prolong delirium. So when are pharmacologic approaches necessary? So always try non-pharmacologic approaches first and having the family to the bedside. And you have to kind of talk to them and train them a bit, and to train your staff in de-escalation procedures and just the calming communication, recommunicating, just staying very calm can make a huge difference. And again, reserving the pharm treatment, which is still antipsychotics, for patients at risk of harming themselves or others. Whenever you prescribe, just do the lowest dose for the shortest period of time. And if the patient previously has been on an antipsychotic, it's very useful to know that. And maybe you start with that one again, because hopefully it was effective the first time. Okay, so this again comes from that ET-DEL toolkit, but just gives some helpful advice about contraindications, risks, doses to start at, etc. And in general, use the lowest dose you can. Depending on how quick you need the onset, you may need to go to IV or sub-Q or IM sources. Olanzapine does come in a sublingual liquid form that you can administer. And so just be aware of the different routes. QT prolongation is a risk, and many hospitals, depending on your criteria at your hospital, may require that patients be monitored for instance, for IV Haldol, because there is a risk, definitely a risk for QT prolongation and torsade. Okay, so take-home messages. Delirium is common, it's serious, tremendous healthcare costs and policy implications. You can improve recognition using something like the UPCAN, which takes less than a minute. Prevention is the mainstay of management, and we've already talked about treatment approaches and reserving those for patients who are a danger to themselves or others. And so, I'm in geriatrics, and our goal always is to have patients creating new memories, not losing their memories and their brain function, and in roles that they enjoy to the end of their days. So really focusing on delirium as a quality of life issue. I always want to imagine a world without delirium. So if you're interested in learning more, here's how you can contact me. I'm still on Twitter occasionally, or X as it's now known. This is the help program, how you can reach to find out more about it. It's now run through the American Geriatric Society. They have the exclusive licensing rights for help. And I do have a delirium research network called NIDUS. And this is the website if you're interested in signing up, if you're interested in delirium research. We do award pilot grants. We have intensive training courses. We would love it if you would consider getting involved. Okay, and I think this is more about NIDUS. Oh, applications for our next boot camp. That's our intensive training course. It's in person in North Carolina. Most beautiful facility you can imagine. Applications are due July 8th. Very, very short applications, but you do have to have a research project in mind. Applications are due July 8th. It's a wonderful experience. It's purposely kept very small. And so I don't think it's ever larger than 15. We try to keep it between 10 or 15. There are as many faculty there as there are attendees. You'll get such individualized attention. I'm always there. There's a lot of other world experts in delirium. And so it's really a way to get started in delirium research. And I want to acknowledge NIH who funded that. Okay, now that's the end. Okay, so we have a little bit of time for questions. I'm sorry I didn't leave too much. Can we unshare?
Awesome. Thank you so much, Dr. Inouye. For anyone who has not yet submitted any questions they may have, please feel free to drop those in the chat. We do have just a couple minutes here. Dr. Inouye, the first question that came in was whether, in the absence of a structured volunteer team that can help with recreational activities and reminiscing, can family at the bedside be trained to do this with structured daily goals?
Yes, indeed. Family can be trained to do that. And we actually have a clinical trial testing that. Yes, thank you. And so, yes, that would be encouraged. And in fact, that's a model that has already been done and tested in China in a clinical trial. And I think there was also one in Germany. And so, so it is effective and it can be done. So it's a really good question.
Awesome. The next question is one that I think comes up with our inpatient teams and our resident teams frequently. If a patient's delirium cannot be controlled with non-pharmacologic therapy and they're a danger to themselves or others, is there a specific antipsychotic from the table you presented that you reach for first?
Yeah, so up to about 3 years ago, I always advised haloperidol because it is still in some guidelines and was felt to be more effective than the newer antipsychotics. But in more recent head-to-head trials, there's really no difference in the various antipsychotics. And I actually do think this, the newer antipsychotics, second generation, have slightly less side effects. And so I choose them more based on, if you need sedation, then I might go with Seroquel, for instance. It's a bit more sedating. If you need a sublingual form, then I might go with olanzapine. I do use risperidone. I do use olanzapine as well. And so it's more sort of the comfort level that you have, how quickly you need the onset, whether someone can swallow a PO med, and so forth. It turns out to be more of those considerations. The other thing to be aware of, well, I talked about the QT prolongation as a major adverse effect. But if someone has Lewy body dementia or could have Lewy body dementia or is Parkinson's disease, you do want to avoid the antipsychotics. They can make the Parkinson's much worse. They can make the dementia much, much worse. And so in those cases, you may want to choose other routes like sedating antidepressants, for instance, or you may have to resort to a short-acting benzo to try to calm the patient.
Awesome. Maybe in our last minute here, I'll give you one more question that came through the chat. Thinking of the long-term complications, do you think delirium is causative in long-term cognitive decline? And if so, how should we be monitoring patients? I think it's patients who have had delirium once they've left the hospital and are in the outpatient setting.
Yeah, it's such a great question, and it's still not clear. I think evidence is stacking that delirium it's very clear that delirium can accelerate cognitive decline in someone who's already on that path towards decline. So if they have MCI or if they have dementia, there's no question that delirium can accelerate that, and that acceleration can be long-term and irreversible. Okay, but that's not the question that was asked. It's, does delirium itself cause permanent damage or permanent change to the brain? And this is an area that I'm extremely interested in. And in fact, I've had $25 million in funding to try to elucidate that question, and we still don't know. What would really need to be done, and just can't really be done, right, is to randomize people and then observe who gets delirium and who doesn't, and then follow them very long term. Unfortunately, that's not something that can feasibly be done or ethically be done. And so I don't think that type of study will, to give us a definitive answer. But I think once there is an effective treatment for delirium, which I'm very hopeful for in the next few years, once we have that effective treatment, we can randomize people to that treatment and we can follow them long term and see if we have less dementia. That will be the way. We have to get the answer definitively to that question. But for now, there's lots of evidence that delirium does make things worse, whether or not it's the delirium itself, or whether it's the ICU stay and hypoxia and other things that were happening, right, that cause the worsening in the brain function. I think that we have enough evidence that we need to try to prevent the delirium, and that ultimately I think it's going to be much better for the patient.
Awesome. Thank you so much. This has been a fantastic presentation on, I think, a really important topic, and it sounds like there will be lots more to come in the future. It is 1:02, and I see folks are having to hop offline. Thank you so much to everybody who attended today. Thank you to you, Dr. Inouye, for coming out, and to the Division of General Internal Medicine for having you. It's been really a pleasure. I apologize for the questions in the chat that we did not get to, but I'll look forward to seeing everybody back for the next Department of Medicine Grand Rounds in 2 weeks.
Thank you.
Thank you.